and all delegates. Next couple of minutes, I will talk a search to identify the etiology of primary acquired nasolacrimal duct obstruction, route of source, nasal or ocular. I have no financial conflict or any relationship. As we know, primary NLDO is a common cause of epiphora in adult population. Pathogenic organism as well as flora, nose, conjunctiva may have a direct role on the pathogenesis. Chronic asymptomatic infection can lead ultimately PANDO. Recent works of PANDO related all lots of works on histology, endoscopic evaluation, as Dr. Tansu sir mentioned, that is a mini endoscope, balloon necrocystoplasty, laser surgery, endonasal, everything. But etiopathogenesis of PANDO, what do you know? As Dr. Professor Javed already mentioned in one journal. On his conclusion, I want to say that etiopathogenesis of PANDO appears to be multifactorial. As per the review, there is a need for focused work on clinician and scientists, and the answer can have far-reaching clinical application. On clinical, there is a very limited studies. Of course, there is a two school of thoughts regarding the route of infection. It may be integrated through conjunctiva or it may be a nose. Those are the points where we can go for a from the source from conjunctiva, and next one is from a nose. Of course, maximum studies on etiology of PANDO did not try to find out the primary source of infection. Here, in this study, I tried to find out the source which may contribute to the pathogenesis. So it may be nasal or ocular. To know the, along with the secondary is to know the spectrum of the microbiology. Along with that, so we can treat, we can prevent secondary infection. That's second. But it was conducted as a prospective study. Place of work was in 3. I was in earlier Sankarav Netralayas, so it was started that there, and right now I am working at Retina and Eye Care Center both. So it was study period from 2015 to December 2022. Ethical clearance was taken institutional, and a total of 300 unilateral cases, 189 were female and 119 were male. Inclusion criteria: chronic necrocystitis, laterality, gender, race, age are not a factor. All adult 18 years or up to 70 years included. Exclusion criteria: of course, there is a congenital cases, traumatic cases, and any evidence of nose infection or something, then acute attack, of course, all we all are excluded. Diagnosis was present on our standard clinical practice. ENT evaluation was done in all cases. But the important is that I am collecting the 3 specimens for each cases. First, one from anatomical site of the opening of the NLD at the inferior meters through the endoscope or under the direct visualization of the endoscope. And second one from the involved side of the conjunctiva on the day of operation. And third one from the lacrimal sac under operating microscope. So 3, one from sac area, 1 nose, and the conjunctiva. And 3 specimens was collected in 3 different, 1 preoperatively in the endoscope, another one during operation under the microscope. The material was collected with a sterile cotton tip and it was processed within 15 minutes. Results. The results were the 77.3% of the overall microorganisms cultured were gram positive, with a predominance of Staphylococcus obviously as per our rule. And in case of a bacillus group, and in case of a nose, there was a bacillus group was present mostly. Growth was observed in 220, 76% in conjunctiva, 268 in lacrimal sac, and 272 in a mucosa. Those are the some pattern of my studies. But very interesting point is that common association. If I look the common association, the sac and nose and the sac and the conjunctiva is the highest, very very significant in conjunctival sac is common. Most of the time, it may be a single, it may be a multifactorial, or in the nose and sac is less, only 33.7%. But there is a association all. So on that ground, I want to say the current study not only contribute the knowledge of organism of the sensitivity, also contribute to the source. We can try to identify the source where it can statistically significant high association of common organism between lacrimal sac content and conjunctival sac indicates that antigen infection plays a crucial role over retrograde spread. Antigen infection is mostly responsible for chronic dacrocystitis. Knowledge of the source infection and early stage, thus increasing the possibilities of early prevention of disease. For a preventive point of view, we are looking all after the DCR or so many studies. But if we think for infection to overcome, just like is a thing under occulty, it may be a game changer in preventive aspect. To detailed knowledge about the pathogenic organism and their source along with the route of the spread will help to us to prevent the etiopathogenesis of Pando. Proper care at source certainly a game changer to prevent Pando, because it's a very challenging and very difficult for the patient. Those are my literatures. Thank you.
Two questions.
Yes.
When we are taking this sample, so cotton soft conjunctival and then from sac, so that is during the surgery.
First, that initially before
sequence
just before entering the OT or during endoscopic examination. One example from the nose under the visualization of endoscope. Second,
first nasal sample. Or it's
yeah,
random
nose,
for all patients.
nose,
First
all patients.
First
nasal sample, then conjunctival sac, and during the time of operation from the sac area.
No, so endoscopy you are doing pre-surgery or it's during the evaluation? There is a
evaluation. It is evaluation, because I am not doing endoscopic surgery, so I am doing a endoscopic evaluation.
1 to 3 days gap between these samples.
Sometimes 2 days, sometimes 3 days, depends on
but
the.
They are not on the same sitting.
Same day also. If that it is sometimes in same day, so I present in, or sometimes in 1 day ahead. It depends on my load of surgery.
If you subdivide your data and check,
yes,
will there be a difference of sample from all 3 sites in same sitting versus different days?
Within to 24 hours. Only in few cases it was in just a pre-operative day. Only within 24 hours, but in all 24 hours, not beyond 24 hours. Because of the it is the availability of OT. Sometimes in maximum time I am using the endoscopic first evaluation swab, then I take the conjunctival swab, then block, then the surgery till time, the third one.
And when we are operating, the standard step is that after all the your dissection, when you're making flap, normally we dilate and we put a probe and make flap over probe. Most of us
yes, this is a standard. Yes, I agree. This is a standard technique, but for this study it was not done, because with little experience also you can also understand that without direct visualization on the microscope you can identify sac infection is not a issue. So for some to detect some pre-existing canalicular obstructions, I am doing probing at the end after making the sac. For this 300 cases I am doing without dissect the sac. If I am unable to identify the sac, in such cases it was excluded.
And
sir, my one question is
one question is that if we assume that NLD obstruction is a complete fibrosis,
yes,
if we go by that premise that in NLD obstruction there is a complete fibrosis, and that will also act as a barrier of any retrograde communication from nose.
Yes.
So your results, when you show that there is because ultimately the conventional thing is that the sac infection will go either from the conjunctival flora
or retrograde. Yes.
But in the final result, both are not correlating. The nose one is some 33%.
Yes.
And conjunctiva it is 50 or something. So why it is not correlating more with conjunctiva? What is your hypothesis on that? Because if we think, we would expect it to correlate more with conjunctiva, assuming that there is no retrograde infection because of fibrosis. This is a kind of a
yes. So there is that is organisms are same in some cases. That indicates the main source of that Pando is either from a conjunctiva which was taken and either from the nose. So that is sometimes not in all the times. There may be a mixed infection. There is some conditions where there is 2 organisms intersect. There is one organism in the nose. There is 2 organisms in the conjunctiva. 1 organism in the sac. But there's in combine. I want to try to combine. So what are the combination of conjunctiva and the sac and combination of the nose and the sac? In the nose basically is bacillus. So chances of retrograde infections I think that antegrade infection is more vulnerable to create the Pando than retrograde. That's my interpretation.
All these cases were complete obstruction, or they were also partial obstruction?
All complete obstruction. All complete obstruction. Yes, in that criteria is it should be there should not be any partial obstruction, and there is a minimal plus positive. Syringing was not done in all cases. earlier syringing, because on the basis of clinical examination it was included. On the basis of clinical examination, most of the time, because there may be some fallacy from during conjunctiva, there may be a mix up with conjunctiva, and that may be possibilities. So as Rop plus was minimal or epiphora, all other tests was done, and on the basis it was detected as a, and of course X-ray is a mandatory in some cases.
For DCR, you don't do syringing in all patients?
No, if the Rop plus is positive, no need for any.
Sir, my question is, generally before the surgery we do the painting with the betadine solution, and you will taken the swab for culture on the OD.
Yes, very good
So,
question. So just what I am using as a presbyopia, so I am using the microscope for before any injection, periocular injection, anesthetic injection, or betadine pain. Conjunctival swab just either from the slit lamp, but it did always within 24 hours from the conjunctival cul-de-sac. One swab for conjunctiva, one swab from the sac that was during the time of operation, during the making, just opening the lacrimal sac flap.
This cases will be all the cases are having already fibrosis on that. Only after that you have done this test.
Yes, NLD full.
You are advised to the house. Because the cases already fibrosis, they are already informed.
Yes.
So what do you advise to the house?
It is a yes, that is, we want to highlight most of our research are on Pando we are not doing any conjunctival swab, we are not examining anything. Suppose there is a conjunctivitis, we can go for it. May be some infectious, it may be a viral, it may be a bacterial, we cannot think it is only allergic one. So my take home message later on in our cases, if we want to prevent, that paper is on the preventive aspect. If we can think there may be a cause, that conjunctivitis, it may be a bacterial, that may also lead a pando, some nostril infection, that also may land up with NLDO. So in such scenario, so we can take care in such a scenario. Those are patients are coming for our OPD or to the ENT surgeon, so we can prevent. Because as a lacrimal surgeon, it is very easy. Okay, I am doing this flap, two flap, that's. But for the patient point of view, it is a little difficult surgery. And in endoscope, and some surgeons prefer it is under GA. The cost of in our India is cost of GA is around 45,000. This is the minimum cost under endoscopic surgery.
More than that.
Yes, but still in a low cost also 50K. So 50K is for not a easy one for endoscopic, and for external also, if we consider, and always a frustrating for our, if we compare the cataract surgery.